Hello, good evening and welcome to today's discussion with PLAB-1 Clinic. All right, so we are going to continue with central nervous system questions and answers. Now, the first question here is about a homeless person who is found wandering on the street. He had ataxic gait, nystagmus, and ophthalmoplegia. Right? He looked unkempt, and his clothes had a sweaty odor. Had a dry mucous membrane with a blood pressure of 118/70 millimeter of mercury and pulse rate of 90 beats per minute. Blood sugar level is 8. Alcohol breath test is negative. What will be the most important initial investigation? First option says IV insulin. This question, they asked what will be the most important initial investigation? Always talking about IV insulin, Bico, bolus, IV dextrose, antibiotic. I think there's something wrong with the question. What do you think, Noya? Skip it. Right. Take note of it and then see. What was the question? What will be the most important initial investigation? Okay, maybe initial treatment, right? Okay, so maybe this was where the error was from. Probably right. All right, so you think it's vitamin B? Why? Blood sugar level is 8. That should be in millimole per liter. He had ataxic gait, nystagmus, and ophthalmoplegia. What does this three things suggest? You chose vitamin B now. Like, what was going through your mind? Okay. Ataxic gait, nystagmus, and ophthalmoplegia. Okay. Okay. That's Korsakov Syndrome. Okay. Looked unkempt and his clothes had a sweaty odor. He had a dry mucous membrane with normal blood flow, normal pulse. Sugar level was normal. Acid alcohol breath test was negative. And that was, and he's not hypoglycemic. Neither is he hyperglycemic. Well, that sugar level though is borderline. I think you may have a point. IV insulin is not IV insulin. If it's Corsikov, then vitamin B will help. This is Wernicke's encephalopathy due to alcohol withdrawal. So vitamin B complex should be checked. This occurs mainly due to thiamine deficiency. Okay. What we're gonna familiarize ourselves with Korsakov Syndrome. Yes, that's very, very wicked. So how I think it's just the clincher that they already gave you, because maybe they're trying to imply that the patient did not drink alcohol like around that moment when that was probably why they put it that the alcohol breath test was negative. So like that the patient didn't take alcohol like recently. I think that's implication of that point also there.
Learning medicine is hard work. Learning medicine is hard work. Osmosis makes it easy. It takes your lectures and notes to create a personalized study plan with exclusive videos, practice questions, and flashcards, and so much more. Try it free today. Vernica-Korsakov syndrome is named after Karl Vernica and Sergei Korsakov, the physicians who discovered the condition in the late 1800s. Vernica-Korsakov syndrome is caused by vitamin B1 or thiamine deficiency, and it refers to a spectrum of disease. Wernicke's encephalopathy is the acute, reversible stage of the syndrome, and if left untreated, it can later lead to Korsakov syndrome, which is chronic and irreversible. Thymine is typically stored in the liver and absorbed in the duodenum and then moves throughout the body, where it's involved in numerous cellular processes that require thymine. The enzyme thymine pyrophosphate synthetase transfers a pyrophosphate group from ATP to thymine, turning it into the coenzyme thymine pyrophosphate, which is the metabolically active form of thymine. Now, as a coenzyme, thymine pyrophosphate functions to assist other enzymes carry out reactions, like pyruvate dehydrogenase, alpha-ketoglutarate dehydrogenase, and transketolase, particularly regarding glucose metabolism. Furthermore, within the brain, thymine pyrophosphate helps metabolize lipids and carbohydrates as well as maintain normal amino acid and neurotransmitter levels. In some neurons, thymine even helps with propagation of neural impulses down the axon. Given its multifaceted role, a deficiency of thymine can have serious consequences. Specifically, thymine deficiency impairs glucose metabolism, and this leads to a decrease in cellular energy. One of the major causes of thymine deficiency, and therefore Wernicke-Korsakov syndrome, is alcohol abuse. Alcohol leads to decreased thymine levels in various ways. First, alcohol interferes with the conversion of thymine to its active form, thymine pyrophosphate, by blocking the phosphorylation of thymine. Second, thymine is normally absorbed through the first portion of the small intestine, called the duodenum. However, ethanol prevents this absorption process, and it's believed that alcohol does this by reducing the gene expression for thymine transporter 1 within the intestinal brush border. Third, chronic alcohol abuse can lead to fatty liver or cirrhosis, which interferes with the storage of thymine within the liver. Other causes of thymine deficiency are inadequate intake, like in malnutrition and anorexia, or due to malabsorption, like in stomach cancer and inflammatory bowel disease. The brain is especially vulnerable to impaired glucose metabolism, since it utilizes so much energy. Early on in thymine deficiency, the cerebellum gets affected, and that can affect movement and balance. In addition, the brainstem can be affected, and that's the region that gives rise to the cranial nerves that provide motor and sensory innervation to the face and eyes. If the medulla region of the brainstem is affected, it can impair the heart rate and breathing. Later findings in thymine deficiency are hemorrhage and necrosis of the mammillary bodies. The mammillary bodies are two small round structures located under the brain and are part of the limbic system, which is responsible for memory, emotion, and behavior. Now, Wernicke-Korsakov syndrome can be thought of as a spectrum of disorders. Wernicke's encephalopathy symptoms happen first, and can eventually develop into more severe symptoms found in Korsakov syndrome. Wernicke's encephalopathy is characterized by ophthalmoplegia, meaning weakness or paralysis of the eye muscles, as well as ataxia or unsteady gait, and changes in mental state like confusion, apathy, and difficulty concentrating. And untreated Wernicke's encephalopathy can lead to coma and death if not treated quickly. Korsakov syndrome, on the other hand, mainly targets the limbic system, causing severe memory impairment. This includes anterograde amnesia, which is the inability to create new memories, as well as retrograde amnesia, which is the inability to recall previous memories. One of the characteristic findings of Korsakov syndrome is confabulation, in which the person creates stories to fill in the gaps in their memory which they believe to be true. not too different from what young children sometimes do in retelling a story. Diagnosis of Vernica-Korsakov syndrome is typically made by clinical impression of the presenting symptoms, as well as basic blood and liver function tests to measure thymine levels. Sometimes diagnosis can be confirmed by an MRI, which would show degeneration of the mammillary bodies. Vernica's encephalopathy is considered a medical emergency and must be treated immediately to prevent the development of Korsakov syndrome. The therapy is an infusion of thymine over a few days to get rid of the deficiency. It's usually given alongside glucose, but it's important to normalize the thymine levels first, because without thymine pyrophosphate, most of the glucose will become lactic acid, and that can lead to metabolic acidosis. Alright, as a quick recap. Vernica-Korsakov syndrome is caused by thymine deficiency and is commonly seen in chronic alcoholism. It's a combination of Vernica's encephalopathy, which consists of the triad of ophthalmoplegia, ataxia, and confusion, and if left untreated might result in Korsakov syndrome, which manifests as aphasia and confabulation. Treatment involves the prompt administration of thymine, followed by glucose.
Learn medical knowledge more efficiently.
That was a very interesting one. I believe Vernica-Korsakov syndrome.
Like in malnutrition and anorexia, or due to malabsorption, like in stomach cancer and inflammatory bowel disease. The brain is especially vulnerable to impaired glucose metabolism, since it utilizes so much energy. Early on in thymine deficiency, the cerebellum gets affected, and that can affect movement and balance. In addition, the brainstem can be affected, and that's the region that gives rise to the cranial nerves that provide motor and sensory innervation to the face and eyes. If the medulla region of the brainstem is affected, it can impair the heart rate and breathing. Later findings in thymine deficiency are hemorrhage and necrosis of the mammillary bodies. The mammillary bodies are two small round structures located under the brain and are part of the limbic system, which is responsible for memory, emotion, and behavior. Now, Vernica-Korsakov syndrome can be thought of as a spectrum of disorders. Vernica's encephalopathy symptoms happen first, and can eventually develop into more severe symptoms found in Korsakov syndrome. Vernica's encephalopathy is characterized by ophthalmoplegia, meaning weakness or paralysis of the eye muscles, as well as ataxia or unsteady gait, and changes in mental state like confusion, apathy, and difficulty concentrating. And untreated Vernica's encephalopathy can lead to coma and death if not treated quickly. Korsakov syndrome, on the other hand, mainly targets the limbic system, causing severe memory impairment. This includes anterograde amnesia, which is the inability to create new memories, as well as retrograde amnesia, which is the inability to recall previous memories. One of the characteristic findings of Korsakov syndrome is confabulation, in which the person creates stories to fill in the gaps in their memory which they believe to be true. Not too different from what young children sometimes do in retelling a story. Diagnosis of Vernica-Korsakov syndrome is typically made by clinical impression of the presenting symptoms, as well as basic blood and liver function tests to measure thymine levels. Sometimes diagnosis can be confirmed by an MRI, which would show degeneration of the mammillary bodies. Vernica's encephalopathy is considered a medical emergency and must be treated immediately to prevent the development of Korsakov syndrome. The therapy is an infusion of thymine over a few days to get rid of the deficiency. It's usually given alongside glucose, but it's important to normalize the thymine levels first, because without thymine pyrophosphate, most of the glucose will become lactic acid, and that can lead to metabolic acidosis. Alright, as a quick recap. Vernica-Korsakov syndrome is caused by thymine deficiency and is commonly seen in chronic alcoholism. It's a combination of Vernica's encephalopathy, which consists of the triad of ophthalmoplegia, ataxia, and confusion, and if left untreated might result in Korsakov Syndrome, which manifests as aphasia and confabulation. Treatment involves the prompt administration of thymine, followed by glucose.
All right. Dr. Agatha, you're welcome. All right, we just finished learning about Korsakov Syndrome. Right. Dr. Noya, you asked a question. You said, please, can IV vitamin B could be given bolus? Yes, it can. It can be given bolus. Usually, what we even give here is like 100 milligram IV thiamine, 100 milligram, 12 hourly. All right. But most times over here, we don't find the IV. So we end up giving orals. The oral is still 100 milligram. So we commonly find the oral, but we don't find the IV to give bolus like that. But generally, we just give vitamin B complex. All right. You put, that's how they calculate it. Like, for example, if you are treating a patient that has chronic liver disease, because they are prone to hypoglycemia, they are also prone to thiamine deficiency. All right. So you want to, as you are correcting the hypoglycemia, you know the maintenance fluid for them is not normal 5% or normal saline. What you give them is 10% dextrose water, and you give them 500 mils 6 hourly. Yeah, do you understand? 500 mils of 10% dextrose water 6 hourly. So in each of those fluids, you have to put 5 mils of vitamin B complex. So there's a calculation that is involved that implies that first of all, the amount of glucose that is needed a day is about 200 grams. Right. So if you calculate the amount of glucose in 2,000 mils of 10% dextrose water, that will give you the daily requirement of glucose. Right. So let's continue. A 52-year-old man presents with visual hallucinations and features of cognitive impairment. What's the most likely diagnosis? 52-year-old man who presents with visual hallucinations and features of cognitive impairment. What's the likely diagnosis? 1, frontotemporal dementia, Lewy body dementia, delirium tremens, Alzheimer's disease, Huntington's disease. The clinchers: 1, the age, all right, and 2, the presenting complaints, visual hallucinations and cognitive impairment. My video is on. Dr. Noya, can you hear me? I've already turned down the video now. Video has ended a long time ago. All right. I think it's Lewy body dementia, visual hallucinations, and features of cognitive impairments. All right, let's see. Oh, you mean that the video is still playing for you? Then just watch it. Or you exit the class and return. Maybe it will go by then. Because how the video is that when you join a video class, it will start for you afresh. But if I were her, I would have just listened to it. She wants to catch up. All right. Lewy body dementia, right? Welcome back, Dr. Agatha. I believe your video has normalized. Lewy body dementia. You can hear me now, right? You're welcome. You're welcome, Dr. Bishop. Symptoms include dementia, abnormal behavior during REM sleep, that's rapid eye movement sleep, fluctuations in alertness, visual hallucinations, Parkinsonism. Usual onset is after the age of 50, median age of 76. Duration is long-term, causes are unknown. Diagnostic method is based on symptoms and biomarkers, all right? Differential, Alzheimer's, Parkinson's disease, dementia, certain mental illnesses, vascular dementia, medication, acetylcholinesterase inhibitors such as donepezil, rivastigmine, right? Accompanied by changes in sleep, behavior, cognition, movement, and autonomic bodily functions. Memory loss is not always an early symptom. The disease worsens over time and is usually diagnosed with cognitive decline. Usually diagnosed when cognitive decline interferes with normal daily functioning. Sorry guys, I have a call. Just be reading on your own, all right?
What is dementia with Lewy bodies? Dementia with Lewy bodies is a less common type of dementia. It is closely related to both Alzheimer's disease and Parkinson's disease. Lewy bodies are tiny clumps of protein that develop inside nerve cells. They prevent the cells from communicating properly by disrupting the important chemical messengers between them, eventually causing the cells to die. As yet, we don't know how or why Lewy bodies form. Dementia with Lewy bodies can affect any part of the brain, leading to many different symptoms. These include difficulties with movement and deterioration in physical abilities, problems with concentration and alertness that often vary from day to day, and visual hallucinations, when people see something that isn't really there. This may occur when cells involved in processing visual information are damaged, sometimes causing people misperceptions of things that are seen. As with Alzheimer's disease, the symptoms of dementia with Lewy bodies get worse as more nerve cells are destroyed or damaged. As this happens, a person's memory is more likely to be affected. Developing strategies to remember things and using memory aids may help people cope with memory loss. Dementia with Lewy bodies can cause hallucinations that may be very distressing, both to the person with dementia and those around them. The hallucinations may be of people or animals. During an hallucination, it is more helpful to reassure someone that you are there to support them, rather than tell them that what they are seeing is not real. Dementia with Lewy bodies can cause disrupted sleep, as well as vivid dreams that the person may try to act out while sleeping. Exercise during the day and reducing daytime napping can help with some of these sleep disturbances. The medications that help with the symptoms of Alzheimer's disease can also help for dementia with Lewy bodies. Some of the medications used for Parkinson's disease can be beneficial for problems with movement. Health professionals, such as neurologists, occupational therapists, and physiotherapists, can assist with any movement problems caused by the condition and try to maintain a person's independence and mobility. It is closely related to both Alzheimer's disease and Parkinson's disease. Lewy bodies are tiny clumps of protein that develop inside nerve cells. They prevent the cells from communicating properly by disrupting the important chemical messengers between them, eventually causing the cells to die. As yet, we don't know how or why Lewy bodies form. Dementia with Lewy bodies can affect any part of the brain, leading to many different symptoms. These include difficulties with movement and deterioration in physical abilities, problems with concentration and alertness that often vary from day to day, and visual hallucinations, when people see something that isn't really there. This may occur when cells involved in processing visual information are damaged, sometimes causing people misperceptions of things that are seen. As with Alzheimer's disease, the symptoms of dementia with Lewy bodies get worse as more nerve cells are destroyed or damaged. As this happens, a person's memory is more likely to be affected. Developing strategies to remember things and using memory aids may help people cope with memory loss. Dementia with Lewy bodies can cause hallucinations that may be very distressing, both to the person with dementia and those around them. The hallucinations may be of people or animals. During an hallucination, it is more helpful to reassure someone that you are there to support them, rather than tell them that what they are seeing is not real. Dementia with Lewy bodies can cause disrupted sleep, as well as vivid dreams that the person may try to act out while sleeping. Exercise during the day and reducing daytime napping can help with some of these sleep disturbances. The medications that help with the symptoms of Alzheimer's disease can also help for dementia with Lewy bodies. Some of the medications used for Parkinson's disease can be beneficial for problems with movement. Health professionals, such as neurologists, occupational therapists, and physiotherapists, can assist with any movement problems caused by the condition and try to maintain a person's independence and mobility.
I just found a resource for us. Okay. And this one is related to trying to actually differentiate Alzheimer's from dementia. But based on this video alone, you already understand that Lewy body dementia will present very early with visual hallucinations, all right? Unlike Alzheimer's that presents after 4 years before you start having visual hallucinations. Alzheimer's comes first with memory loss, all right? Okay, and it's very much progressive. Then Lewy Bodies comes first with hallucinations, especially visual. I see things that are not there, and even animals and people. Then this sleep wahala. Alzheimer's has hallucination, but it comes late. Okay, so let's look at this table that shows that tries to differentiate Alzheimer's from Lewy bodies based on their characteristics, right? Prevalence, most common 60%. Okay, Alzheimer's is the most common, all right? 60 to 80% of dementia cases is Alzheimer's. So when you see a patient with dementia, think of Alzheimer's first, except when they now start giving you some special features. Okay, then Lewy body dementia is the third most common, 5%, 5 to 10% of cases. So which one will be the second most common now? Maybe frontotemporal dementia. The median survival time, 8 to 6 years. Sorry, what's this? 84.6 years old. Okay, this one is 78 years old. All right. Antipsychotic medication sensitivity, less prone to side effects in Alzheimer's disease. Then dementia, Lewy body dementia, they are more prone to side effects. Then physical abilities tend to be affected during the later stages in Alzheimer's disease, that's physical ability. Then Lewy body dementia tend to be affected during the earlier stages. So someone with Lewy body dementia, it kind of progresses very fast because the person starts having physical disabilities very early, start having visual hallucinations very early. Then in Alzheimer's disease, visual hallucinations less prominent and occur much later, all right? Then in Lewy body dementia, more prevalent and occur earlier. Okay, so I think these are just the highlights of the situation. Okay, dementia by itself implies there is a memory loss, but it's the other characteristics that follow it that will help you to determine what type it could be. So let's see frontotemporal versus Alzheimer's. There's another type of vascular dementia. That one has this rapid kind of, it follows a stroke, is like post-stroke dementia, all right? So it has this very rapid, like step-like progression. A person could be at this level, all of a sudden, bam, person is at this level, all of a sudden, okay? Unlike Alzheimer's that is progressive, gradual, progressive, going downwards, progressive, but vascular dementia, like this stepwise. All right, so for, so this was not what I searched for, but that's what I'm getting. So we'll just look at this and use it to see. All right. I wish I actually saw the. All right. Yeah, sudden onset. Thank you. So differential diagnosis for dementia. So here we have Alzheimer's disease. It's the most common form of dementia. All right. The patient exhibits cognitive or behavioral symptoms that interfere with the ability to function at usual activities. A decline in previous functioning levels not explained by delirium or a major psychiatric disorder, impaired ability to acquire and remember new information as short-term, as anterograde and retrograde memories, all right? Impaired reasoning and handling of complex tasks, and changes in personality and behavior. She also demonstrates an insidious onset over within the last 2 years, all right? Slow onset, progressive. clear-cut history of worsening of cognition by family, and amnestic presentation, all right? No evidence of another concurrent neurological disease, okay? Then for vascular dementia, criteria, okay, to rule out cognitive impairment of 2 or more domains: orientation, attention, language, visual spatial functions, and others. Presence of cerebrovascular disease like CVA, and a relationship between the previous two. All right. So if there was on neurological examination, you saw hemiparesis, lower facial weakness like facial palsy, Babinski sign, implying an upper motor neuron lesion, sensory deficit, hemianopia, dysarthria, right? Then you also see evidence of infarcts on MRI, white matter lacuna infarcts and all that, okay? That suggests vascular dementia. Then frontotemporal dementia, the hallmark of FTD is a gradual progressive decline in behavior and language, with memory usually relatively preserved. Okay, so probably, I'm sure we'll see a question very soon on FTD. And they're trying to say that the hallmark is behavior and language. So this person starts having abnormal behavior and language difficulties, okay, behavior and language, but memory is intact. That's frontotemporal dementia. And we know that the frontal lobe is involved with language, expressive aphasia, right? Expression, motor parts, motor of speech, all right? Then is also involved with personality, behavior, and all that, okay? So if there's an injury to the frontal lobe, we expect something about language and behavior. Then temporal lobe is also involved in language too, but it is involved in the sensory part of language, not the motor. So, but there's preservation of memory relatively. As the disease progresses, it becomes increasingly difficult for people to plan, organize activities, behave appropriately in social or work settings, interact with others, and care for oneself, resulting in increasing dependency on caregivers. Okay. So that's that. Let me see. Let's see whether we can zoom this and see. Yeah. See difference between frontotemporal dementia and Alzheimer's. Age of onset. FTD is rarely above 75. Okay. But Alzheimer's usually increases with age more than 75. Early behavioral problems, very common. Okay. So Lewy body has early visual hallucinations and even physical issues, all right? FTD has early behavioral issues, all right? Early behavioral problems. Then Alzheimer's is more of memory loss, and it's progressive, and it occurs in older people, okay? Which other one now? Vascular dementia is meant to be sudden in onset, and there will be associated other features that implies that there's really a vascular, maybe this person has had a CVA in the past, maybe has had a TIA in the past, or even at present, and maybe unilateral limb weakness, facial deviation, dysarthria, speech deficits, and all that, okay, which suggests vascular origin, and it's always sudden in onset, unlike the others are like progressive, okay? And there may be associated hypertension, diabetes mellitus, all the cardiovascular risk factors could be present, obesity, So socially inappropriate behaviors, common in the early course of FTD. Then Alzheimer's is usually the severe case that you start having socially inappropriate behaviors, all right? Then memory impairment is less prominent in FTD, for early and profound memory impairment in Alzheimer's disease. All right. So memory impairment is the main thing in Alzheimer's disease. Visual hallucinations is the main thing in Lewy body dementia. Behavioral problems is the main thing in FTD. Okay. Then vascular dementia, you start having other things that suggest CVA, strokes. Right. Then language problems may have isolated language problems without memory impairment in progressive non-affluent aphasia type. That's for FTD. So Alzheimer's disease will always, before you have language problems, it will always coexist with a memory impairment. Then visuospatial defect, rare in mild to moderately impaired case, is common in Alzheimer's disease. Motor signs, more common in FTD, motor neuron disease, okay? Less common in Alzheimer's disease. Then mood, there's marked irritability. Of course, there's behavioral things, so you expect the mood to be affected. There's marked irritability, anhedonia, withdrawal, alexithymia. That's difficulty in understanding, processing, or describing emotions. Euphoria, lack of guilty, apathy, or suicidal ideation. Like this person is that you have sadness, tears, anhedonia, apathy, guilt. So the Alzheimer's disease one is more like depression alone, but the one for FTD is more like both mania and depression. So like this all over the place emotions. And psychotic features is rare in FTD. Okay, but Alzheimer's disease usually have the illusion of misidentification. All right. So Alzheimer's can have anorexia and weight loss, but FTD has increased appetite, carbohydrate craving 80%, and even weight gain. Okay, you see that thing we were saying about the manic symptoms. So FTD kind of all right, different from what they were before. So that is FTD for you. And let's see vascular dementia. So the difference between vascular dementia and Alzheimer's disease, like we mentioned, history of atherosclerotic diseases, yes, that's cardiovascular risk factors, transient ischemic attack, strokes, atherosclerotic risk factors, DM, hypertension. But in Alzheimer's disease, there doesn't need to be any associations, it just occurs with elderly age, right? Onset is sudden, okay, maybe sudden or gradual, but Alzheimer's disease is always gradual. Progression is slow or stepwise progression, like I mentioned, it has a stepwise progression, all right? Stepwise progression. But the one of Alzheimer's disease is slow, gradual, progressive, like this, like a slide, okay? Then neurological examination, there will be neurological deficits, of course. When you examine the patient and find out there's weakness or maybe one side of the body, facial deviation, all right, dysarthria, dysphagia even, speech deficits. Then gait often disturbed early for vascular dementia, usually normal in Alzheimer's. Memory, mild impairment in early phase, but there's prominent memory impairment, which I mentioned was the remarkable thing in Alzheimer's disease. All right. Executive function, marked impairment early, then impaired later in Alzheimer's disease. Type of dementia, subcortical in vascular dementia, cortical in Alzheimer's. All right. Hachinsky ischemic score more than or equal to 7. All right. This neuroimaging shows infarction or white matter lesions. Why this one is normal, or hippocampal atrophy, the hippocampus. I think hippocampus is the memory center. Okay, I think so. So hippocampus of the hippocampi, hippocampus function. Remember that. Hippocampus is a complex brain structure embedded deep into temporal lobe. It has major role in learning and memory. It has a plastic and vulnerable structure that gets damaged by a variety of stimuli. Yes, it is the memory center. All right. So we come back. Question 10% with visual hallucinations and features of cognitive impairments. All right. So the key word here is visual hallucinations. All right. And he's 52-year-old. So Lewy body dementia. Okay, a patient with vesicles in the maxillary division of trigeminal nerve. You know, trigeminal nerve, I think, has 3 divisions. There's one ophthalmic division, that's V1. There's 2, which is the maxillary division, that's V2. And there's 3, which is the mandibular division, that's V3. Okay, so they're not telling you there is vesicles in the maxillary division, that's V2 of trigeminal nerve. Which area of mucous membrane will be involved? So just the same way that you are talking about V1, V2, V3, it means it will, if you visualize it, you will understand that the ophthalmic one will supply the upper part of the face. All right. Okay, let's look at it. Mucous membrane. Of course, all this cornea and conjunctiva will be coming from ophthalmic, right? Then, so it's between the cheek and the palate. What do you think? Trigeminal nerve is known to be a sensory nerve, unlike facial nerve that is known to be predominantly motor. The facial nerve still has a sensory division, which is the one that supplies the caudate tympani and the one that supplies the lingual nerve. All right. So, see, trigeminal nerve, that's nerve 5. V1, ophthalmic division, supplying all these places around the eyes, even the scalp. All right. Then V2, where's V2? V2 is this one. Still giving a branch to the upper part. Okay. Then going to the maxilla. Right. Then V3 coming down this way, it has a buccal branch, lingual branch, and what's this? Internal alveolar branch. Okay. So trigeminal nerve is a nerve responsible for sensation in the face and motor functions such as biting and chewing. It's the most complex of the cranial nerves. All right. It derives from the fact that each of the 2 nerves, one on each side of the pons, has 3 major branches: the ophthalmic, the maxillary, and mandibular nerve. The ophthalmic and maxillary branches are purely sensory, whereas the mandibular nerve supplies motor as well as sensory, right? Then let's see, I just want to see the functions. They come from the pons. And see the sensory distribution. One comes from the nose like this to the scalp. This one cuts from here, the upper part of the zygomatic bone, all right, and then to the maxillary area, okay. And this one takes the mandibular area, TMJ, and the tempus, temporal region. Okay. The information we are looking for may not be that well arranged, like straightforward like that. But let's see. So it's the cheek, right? It involves the soft palate, that's the maxilla, the maxillary region. So it covers the cheek. Okay. So it also involves the soft palate, but not the hard palate. So cheek is more complete answer than palate. Okay. All right. A 49-year-old man first presented with increasing difficulty in swallowing. Several months later, he developed weakness in his right foot. Now he can no longer feed himself, took some food, and has become confined to a wheelchair. What is the most likely diagnosis? 49-year-old man who first presented with increasing difficulty in swallowing. Several months later, he developed weakness in his right foot. Now he can no longer feed himself. He chokes on food and has become confined to a wheelchair. 49. Take that. Cerebral tumor, myasthenia gravis, Lambert-Eaton syndrome, motor neuron disease, cerebrovascular disease. What do you think, guys? What's that disease that can, as you can see, there's an obvious progression, all right, from difficulty in swallowing to weakness on one side, now to total body weakness, up to the point that he's now confined to a wheelchair and he can't even swallow again at all, right? And he chokes whenever he attempts to do that. So what do you think? Yeah, likely. It's likely a motor neuron disease, right? MND. Among the options that were here, there's myasthenia gravis. Myasthenia gravis affects majorly the what do you call it? Corticosis now, so extraocular muscles, right? Including Lambert-Eaton is very close to myasthenia gravis, right? Even though there can be generalized muscle involvement, okay, but most times where you see is droopy eyelids, ptosis. That's as a result of antibodies against the acetylcholine receptors, right? Okay, Dr. Chara, is that you? Well done. You are doing well. The key motor neuron disease, the picture is of amyotrophic lateral sclerosis. Yes, that kind of thing that I told you that Stephen Hawkins had. Yeah, this is the type of thing. You're welcome. Good evening. With bulbar onset, what happened now? Was your flight delayed? Your flight was delayed, eh? Okay. So ALS has very bad prognosis, right? A 74-year-old man presents with sudden onset of right-sided weakness and slurred speech. He also has loss of sensation over the right side of the body and visual field defects. CT shows ischemic stroke. What's the most appropriate management? 74-year-old man present with sudden onset of right-sided limb weakness and slurring of speech. That's a stroke, all right? And he has loss of sensation over the right side of the body, same side as the motor stuff, and visual field defects. This shows ischemic stroke. What's the most appropriate management? didn't tell us the duration, how long this thing has lasted. Was it not this type of question that we chose our place for the other time? Yes, now, is this type of question. All right. So they just assume that you should know that once they've told you that present with sudden onset of something that looks like a stroke, and then they told you that they've already done a CT scan, that it's an ischemic stroke, so that you should do something. Abroad, here before we get a CT scan, I'm sure that brain has gone to the rims. All right. Before we get a CT scan, even in my hospital, we have a CT scan. You understand? But with all the logistic factors, and before the CT scan is finally done, okay, there's still some time being wasted. In fact, before the patient comes, they don't even come immediately the stroke happens. They will come like after they've gone to take a go and gbogbo niche and other things from other places before they will come. So minus that one, then intra-hospital delays is also there. So outer place is the answer. Abroad, all right, things are working. So once the patient, as soon as, and patients are educated, all right, so they know that once I have this, I should present to the hospital immediately. The person doesn't waste time, unless it's the poor Oyibo, all right, or the ones that don't have any means, or the ones that are dodging from the system or something. Okay, but most of them, they know what to do. All right, so they present very early, and as soon as they come, straight to CT scan is done. You know what it is, diagnose immediately, start treatment. So outer place is what you should go for. Okay, outer place, even over streptokinase, even though two of them are in the same class, but you pick outer place because what's outer place again? Tissue plasminogen activator. They're all antifibrinolytics. They're all fibrinolytic agents, but I think these newer ones, the TPAs, have been found to be more effective and have less side effects. All right. So the key is outer place. Patient has acute symptoms of patient has acute onset of symptoms, and time of onset is not known. So considering window period of 4.5 hours from onset of symptoms, you can give outer place. So what we know is 2 hours, Abi. A patient presents with mask-like facies. He also has gait problems. Which class of drugs is causing this? This one a giveaway now. Salaka. Antihypertensive, antipsychotic, antidepressant. What do you guys think? Yes, outer place comes before aspirin. I thought you were referring to the previous question, right? Yes, outer place always comes before aspirin. That's depending on the duration. Okay. So if patient comes within 2 hours of onset of the ischemic stroke, right, and you've already done a CT scan, you know that outer place or fibrinolytic agents will be very effective within that time. All right. So you have to prioritize it over every other thing. Okay, you give and then see it gets working. All right. But when a patient now comes beyond the time when you generally expect an fibrinolytic to work, because it said that when you give fibrinolytic agents beyond that time, you are going to the risks now outweighs the benefits. All right. So you're going to end up causing bleeding and may even convert the CVA from an ischemic to hemorrhagic. All right. So the patient present with mass facies Chara, disappointed though. Mass facies, what's the diagnosis? My brother, I never give out a place before. Never see him. Never see him. But I don't know what it looks like. But we can find out. I'll take place. The place is administered IV at a concentration of 1 milligram per ml for the treatment of acute ischemic stroke, pulmonary embolism, and myocardial infarction. The reconstituted solution is stable for 8 hours at room temperature. Recombinant DNA technology is what they use to produce it. So quantitative composition of the lysophilized product. Okay, it comes as 100 milligram per vial, right? It also has another 50 milligram per vial one. Okay, so what's the dose now? Indications: acute ischemic stroke, right? Is indicated by treating acute ischemic stroke. So if possible, within 3 hours after onset of symptoms. After onset of symptoms, not after presentation, after onset of symptoms. Then acute MI. Okay, so stroke, MI, and then pulmonary embolism. The brain, the heart, and the chest. So limitation of use. The risk of stroke may outweigh the benefit produced by thrombolytic therapy in patients whose MI puts them at low risk or death or heart failure. Dosage. Okay, the recommended dose is 0.9 milligram per kg, not to exceed 90 milligram total dose. Okay, with 10% of the total dose administered as an IV bolus over 1 minute, and the remainder infused over 60 minutes. So we've gotten how it's given, right? So let's say it says 0.9 milligram per kg. So the maximum dose is 90 milligram total. Okay, so you divide it 10%, you give it bolus. Okay, 10% of that maximum dose, or 10% of the dose based on the patient's weight, give it bolus, all right, IV. And the rest, you put it in an infusion and put it over 1 hour, that's 60 minutes, right? So during and following altiplase administration for the treatment of acute ischemic stroke, frequently monitor and control blood pressure. In patients without recent use of oral anticoagulants or heparin, treatment can be initiated prior to the availability of coagulation study results. Continue if the pre-treatment INR is greater than 1.7 or the activated APTT is elevated. So similar dose for MI and similar dose for pulmonary embolism. So are you happy now? Can we move on? It's antipsychotic. It's not antidepressant, it's antipsychotic. We've been hammering it now that antipsychotics, one of the side effects, or is it that you missed the diagnosis? This is Parkinsonism, in case you don't know. Mask-like facies. The features of Parkinson's disease, you can go from head to toe. Like you have this mask-like facies. That's to say, like apathy, kind of. So their muscles, they're not responding to anything. Okay, they're not smiling, they are not laughing, they are not angry, they are just there. All right. So then this shuffling gait, right? Have you ever seen a Parkinson's patient taking a walk? They actually drag their feet on the floor like that, shuffling gait, almost like a robot. Okay, just drag their feet for that shuffling gait, right? Then Parkinson's disease. So Parkinson's disease is one of the causes of Parkinsonism, but not all Parkinsonism is due to Parkinson's disease. I hope you understood that. Parkinsonism is like a syndrome, all right? Whenever there is depletion of dopamine in the substantia nigra, you say it's Parkinsonism, but the causes can be Parkinson's disease, okay? Parkinson's disease is like progressive brain neurodegenerative disorder, so mild chronic trauma, like in boxers and people who have had head traumas in the past and all those things, all right? Progressive minor trauma, chronic minor in quotes trauma can cause that. I think there's a place for heavy metal poisonings too. And there's also a family history associated with Parkinson's disease, all right? So I want us to look at it. Who is placed on antipsychotics? Parkinson's? No, they're not placed on antipsychotics. They are placed on anticholinetics that has effects on increasing dopaminergic fibers. That's what Parkinson's disease patients are placed on. In fact, they're giving dopamine itself. That's why they're giving levodopa. And because levodopa is very, very quickly degenerated in the vessel, in the blood vessels, all right? It will quickly be broken down to an inactive form. That's why they give it levodopa plus carbidopa. Carbidopa is an enzyme inhibitor. So it inhibits the enzyme that would have broken down levodopa. That's why they give it together. So you need dopamine. Antipsychotics deplete dopamine because they act on D1 receptors in the brain. So they deplete dopamine over time, especially the typical ones, right? That's the first generation antipsychotics. But the second generation ones don't have less of that side effects. I'm coming. I'll show the question.
Learning medicine is hard work. Osmosis makes it easy. It takes your life away. Parkinson's disease, which is sometimes called Parkinson disease, Parkinson's, or PD, is a movement disorder where the dopamine-producing neurons in the substantia nigra of the brain undergo degeneration. Parkinson's is one of the most common neurological disorders. It's a progressive, adult-onset disease, and it gets more common with age. Most of the time, there's no known cause, but in a few cases there might be a genetic cause, like mutations in the PINK1, Parkin, or alpha-synuclein genes. And in rare cases, Parkinsonian symptoms might be caused by MPTP, a toxic impurity that can be found in the recreational drug MPPP, or desmethylprodine, which is a synthetic opioid. In other people, one or more risk factors, rather than a single outright cause, might contribute to Parkinson's. For example, pesticide exposure or DNA variants in genes like LRRK2. No matter what the cause is, Parkinson's derives from the death of dopamine-producing or dopaminergic neurons in the substantia nigra. The name substantia nigra means black substance, since it's darker than other brain regions when you look at a slice of the brain on an autopsy. We usually refer to the substantia nigra as if it's a single location, but there are actually two of these regions in the brain, one on each side of the midbrain. The substantia nigra is a part of the basal ganglia, a collection of brain regions that control movement through their connections with the motor cortex. In Parkinson's, these darkened areas of substantia nigra gradually disappear. Under a microscope, Lewy bodies, which are eosinophilic, round inclusions made of alpha-synuclein protein, are present in the affected substantia nigra neurons before they die. The function of alpha-synuclein is unknown, as well as the significance of Lewy bodies, and they're both found in other diseases, like Lewy body dementia and multiple system atrophy. The substantia nigra actually can be split into two subregions. First, there's the pars reticulata, which receives signals from another part of the basal ganglia called the striatum, which is a term for the caudate and putamen put together, and relays messages to the thalamus via neurons rich in the neurotransmitter GABA, also known as gamma-aminobutyric acid. Second, there's the pars compacta, and this is the part of the substantia nigra affected in Parkinson's. The pars compacta sends messages to the striatum via neurons rich in the neurotransmitter dopamine, forming the nigrostriatal pathway, which helps to stimulate the cerebral cortex and initiate movement. Therefore, when substantia nigra pars compacta neurons die, the individual might be in a hypokinetic or low movement state, which is commonly seen in Parkinson's. In addition to simply initiating movements, the substantia nigra helps to calibrate and fine-tune the way that movements happen, which leads to the clinical features of Parkinson's. First, there's tremor, which is an involuntary shakiness most noticeable in the hands, characteristically called a pill-rolling tremor, because it looks like someone's rolling a pill between their thumb and index finger. This is a resting tremor, meaning it's present at rest and diminishes with intentional movement. Next, there's rigidity, which refers to stiffness that can appear as cogwheel rigidity, which is when there are a series of catches or stalls as a person's arms or legs are passively moved by someone else. Rigidity is also responsible for the stooped posture and an almost expressionless face that some individuals with Parkinson's might have. Next up is bradykinesia, which is slow movement, hypokinesia, which is lessened movement, and akinesia, which is an absence of movement, and all three result from difficulty initiating movements. Examples of this are having the legs freeze up when trying to walk and also walking with a shuffling gait, or small steps. Finally, a late feature of the disease is postural instability, which causes problems with balance and can lead to falls. Despite these multiple effects on movement, Parkinson's disease does not produce weakness. This helps differentiate it from diseases that affect the motor cortex or corticospinal pathway. In addition, the resting tremor of Parkinson's disease helps to differentiate from cerebellar diseases, which might result in an action or intention tremor, which is a tremor that's essentially the opposite of a resting tremor, where the tremor actually gets worse with movement. Also, both bradykinesia and postural instability help differentiate Parkinson's from essential tremor, of which an action tremor is also a hallmark feature. Non-motor brain functions can be affected in Parkinson's as well, leading to additional common symptoms including depression, dementia, sleep disturbances, and difficulty smelling. These are thought to come about because of dysfunction of dopaminergic signaling in other parts of the brain beyond the substantia nigra, for example in the prefrontal cortex leading to cognitive symptoms, and also possibly from issues with other neurotransmitters like acetylcholine. Fortunately, there are treatments that help with Parkinson's symptoms, although none stop the progressive neurodegeneration. The main strategy here is to increase the amount of dopamine signaling in the brain. Dopamine itself can't cross the blood-brain barrier, but its precursor levodopa can. And once in the brain, levodopa is converted to dopamine by dopa decarboxylase, most importantly within the remaining nigrostriatal neurons. Peripheral dopa decarboxylase also exists, which can metabolize levodopa into dopamine before it gets through the blood-brain barrier, and via additional enzymes, metabolize it into other catecholamines like epinephrine, which can cause unwanted side effects like arrhythmias. This is exactly why levodopa is administered with carbidopa, a dopa decarboxylase inhibitor that isn't able to cross the blood-brain barrier. Another strategy is to use amantadine, which is also an antiviral medication that increases endogenous dopamine production, although the mechanism here is still being worked out. A different strategy is to use dopamine agonists that can stimulate dopamine receptors and basically trick the brain into thinking there's more dopamine than there really is, like bromocriptine, which is an ergot or fungal derivative, as well as pramipexole and ropinirole, which are not ergot derivatives. Alright, the next dopamine-directed class of therapies are inhibitors of COMT, catecholamine O-methyltransferase, which is an enzyme that degrades dopamine and levodopa. COMT inhibitors like entacapone and tocopone are only given with levodopa to prevent the enzyme from breaking it down outside the central nervous system, thus allowing more of it to enter the brain. Very similarly, there are medications like selegiline, which inhibits monoamine oxidase B, also known as MAOB, which is another enzyme that metabolizes dopamine. Since usually there's a balance of signaling between dopamine and acetylcholine, a loss of dopamine reaching the striatum increases the relative amount of acetylcholine signaling there. Therefore, anticholinergics can be given to restore the balance of cholinergic and dopaminergic signaling, like benztropine, which improves the tremor of PD. A special treatment available to help treat PD is deep brain stimulation, which involves an implantable device that directly sends electrical signals to the basal ganglia, which counteracts the aberrant signaling in Parkinson's. The term Parkinsonism is sometimes used to describe symptoms of Parkinson's that are seen in other nervous system diseases, like Lewy body dementia, Wilson disease, and Pick disease, as well as side effects of a medication, like antipsychotics like haloperidol, which blocks dopamine receptors, and metoclopramide, a dopamine antagonist sometimes used to treat vomiting. Alright, as a quick recap. Parkinson's is a progressive movement disorder caused by degeneration of dopamine-producing neurons in the substantia nigra, specifically in the pars compacta, which leads to resting tremor, rigidity, problems initiating movement, and postural instability, and for which therapy primarily focuses on increasing brain dopamine.
All right, guys. I believe we maximized on, yeah. I don't think we'll reach 40% today. Okay, so a 32-year-old woman suffers an episode of severe occipital headache with vomiting and loss of consciousness. She is brought to the hospital where she is found to be conscious when there is normal pulse, there is normal BP with no abnormal neurological sign. What's the next step in her management of severe, single episode, severe occipital headache with vomiting and loss of consciousness? So what do you do next? Admission for observation, CT brain, MRI head, reassurance, discharge home, X-ray score. Sarah, I know you like reassurance. So it's a battle between CT scan and MRI. On this, I'm gonna fight physically. But who answered first? No, yeah, CT scan. So Noya is correct. Even though we know that MRI has good tissue delineation, but unless you actually need to, because one is that it's more expensive. Are you aware? If CT scan is like that's something K, then MRI is like 50 something K, almost 60, almost twice price, right? So except when you need to before you do it. If 50-year-old patient has been diagnosed with multiple sclerosis, presents with a positive Runeback test. She also has weakness and loss of sensations in all her 4 limbs. Which site is most likely to be affected? Cerebral cortex, cerebellum, cervical spine, spinal cord, thoracic spinal cord, brainstem. So yeah, I think it's the cervical spinal cord. Why cervical spinal? Did you follow the question? What does this Runeback test imply? I said it's a test that differentiates the cerebral lesion from dorsal column medial lemniscus sensory loss. Abi? Okay. So when it's positive, it means that the patient that does it mean that both on closing the eyes and both on opening the eyes and closing the eyes that no impulses are being transmitted? Of course, there's paraplegia, which implies cervical. But this is the difference. Let's say now, if the lesion is in cerebellum, of course, you cannot be talking about cervical spine because cerebellum is higher than cervical spine. But if the Runeback test, okay, so if the patient has an ataxia on closing the eyes, that's positive Runeback test. And let's see. Okay, the purpose is to demonstrate the effects of posterior column disease upon human upright postural control. All right. Where is the clinical relevance now? Let's see. Chara 1 and Chara 2. All right. The test arms are held next to the body or crossed in front of the body. All right. The clinician asks the patient to first stand quietly with eyes open and subsequently with eyes closed. The patient tries to maintain his balance. For safety, it is essential that the observer stands close to the patient to prevent potential injury if the patient were to fall. When the patient closes his eyes, he should not orient himself by light, sense, or touch, or sound, as this could influence the results and cause a false positive outcome. Runeback test is called by counting the seconds the patient is able to stand with eyes like this. So the Runeback test, this is what we're looking for. Runeback test is positive when the patient is unable to maintain balance with their eyes closed. Was that what you said? No, yeah. Okay, yeah. As ataxia on closing the eyes because no impulses are transmitted. Losing balance can be defined as for those are column lesions, they cannot maintain balance both on closing the eyes and on opening the eyes. But if it's cerebellar, when they open the eyes, because of the afferent impulses passing through the eyes, right? They'll still be able to maintain their balance. So I believe you guys. Cervical spinal cord. Quadriplegia is the feature of cervical cord lesion. A 45-year-old man has had impaired vision and pain on eye movement in his left eye over the last 5 days. All right. He also knows loss of color vision in the same eye. In the left eye, the visual acuity is up to counting fingers. Okay. In the left eye, the visual acuity is up to counting fingers. When the pupil is stimulated with light, it dilates. His fundus is normal. What is the single most appropriate clinical diagnosis? Let's read it again. 45-year-old man has had impaired vision and pain on eye movement. The visual acuity is so it does the opposite of what it's supposed to do. Right? It's supposed to constrict when all right. His fundus is normal. What is the single most appropriate clinical diagnosis? Acute dacrocystitis, acute iritis, papillitis, retrobulbar neuritis, scleritis. Thank you. Most likely, we'll be having that paradoxical response of the pupil to light. Means it's something up. It has to be coming from the brain for that to happen. Correct. So retrobulbar neuritis, presentation can be described by either optic neuritis or retrobulbar neuritis. Okay. In optic neuritis, there is disc pallor. As in this case, disc is normal. It is a case of retrobulbar neuritis. All right. So it means the closest differential of optic neuritis is retrobulbar neuritis. But in optic neuritis, there will be disc pallor. But disc is normal in this one. Based on the question, his fundus is normal. All right. For a 6-year-old man who is a heavy drinker is brought to the emergency department in a drowsy state. He is responding vaguely to questions. Examination shows nystagmus and hyperreflexia. Mean corpuscular volume is 103, which is elevated. Normal is like 80 to 100. What's the most likely cause of his cognitive impairment? We just answered this question. B1 deficiency, B12 deficiency, folate deficiency, B6 deficiency, alcohol withdrawal. Yeah. What's another name for B1? Thymine. So it's thymine deficiency that is the issue. Patient. Yeah. The key is thymine deficiency. So the patient has confusion, has nystagmus, which indicates Wernicke's encephalopathy caused by vitamin B1 deficiency. So in that case, what will you do? You keep giving thymine until you can increase the level of thymine in the blood. Wernicke Korsakov encephalopathy. Dr. Agatha, are you following? Not seeing your, is it the neuro effects? An 8-year-old boy develops a seizure affecting his right arm. Seizure lasts for several minutes. Right? He doesn't remember anything. What happened? On his CT, lesion in his left hemisphere. What's the most probable diagnosis? Yeah. Korsakoff's is chronic and irreversible. Wernicke's is acute and reversible. Korsakoff's is when it has degenerated the mammillary bodies. You're not seeing the question again. Village people. I think this one is Dr. Agatha's village people that is causing this one. All right. But the question is about an 8-year-old boy who develops a seizure affecting his right arm. All right. Seizure lasts for several minutes. He doesn't remember anything about what happened, right? On his CT lesion, that's when he did a brain CT scan, there's a lesion in the left hemisphere. What was the most probable diagnosis? There's epilepsy, space-occupying lesion, dementia, Huntington's chorea, intracranial hypertension. Also, no, you want to set the question. You want to reset the question. There's no headache. They didn't mention it. He wants to rearrange the question to suit the diagnosis that he wants. I've read the options. How many times would I? So okay, you're really not seeing the screen. But Chara, you're seeing the screen. Your village people are very powerful this night. They're doing you well. No, yeah, maybe you need to go. You need to leave and come back. But it's not from my end. It's from your own end. I can pose the question for you if you are reluctant to leave. You know, this thing is about transmission. So if the transmission does not transmission, there will be an issue. All right. No, the patient actually has a partial seizure. Yeah, transmission omission. Thank you, Tara. Like you're related to that commissioner of police. That it looks like a focal seizure, all right? And the seizure was just affecting one side, just the right arm, okay? And maybe focal seizure, partial seizure with secondary generalization, because patient lost consciousness, all right? Then CT scan shows a lesion in the left hemisphere. What kind of lesion do you think it will show? Maybe likely this thing, left. They didn't mention that he has been having this transmission. His space occupying lesion. No, yeah. They're holding you down today. This is the complex partial seizure, like I mentioned, all right? So it's likely due to a space occupying lesion. Like when you see the symptoms, affecting just his right arm, that's where the seizure. And you know that when there's a lesion on one side of the brain, it will affecting the other side, all right? But it's not generalized. It's not a generalized tonic-clonic seizure. It's just on one side. So which tells you it's a partial seizure. But because the patient lost consciousness, you now know it's a partial seizure with that's complex partial seizure. That's the one that can make a patient to lose consciousness. Okay. So that's it. You know, SOL is a general term. It could be anything. It could be tumors in the brain. It could be bleeding. Could be infection. All right, brain abscess. Anything. There are many things that can cause. It's just a general term. Space occupying lesion. Could be any lesion. Right. The 72-year-old lady is drowsy, and her relatives want to take her home. She has been prescribed diazepam 2.5 milligram. All right. What's the best delivery route? Oral, IV, IM, perectal, subcut. She's drowsy, and her relatives want to take her home. She has been prescribed diazepam 2.5 milligram. What's the best delivery route? I don't understand why you're giving diazepam to someone that is already drowsy. Or is it just normal to just snag them? Snag the patient extra one so that you will enter coma. There's no attempt. Maybe the keyword here is that the patient is already drowsy. So maybe you look for a route that will be very slow. Because the patient is already drowsy. So maybe you look for a slow. You may be correct, or maybe there's another rationale. But if it's what I'm thinking, then no, yeah. Relate to everybody. Perectal. Why is it perectal? Like, what's the rationale? No rationale. Perectal and peroral, which one do you think is faster? Okay, perectal will be very slow. Yeah, you say rectal is faster, you say rectal is slower. Rectal is faster because of hemorrhoidal veins. So what's the idea of this question? Patient is already drowsy. You're also giving it through a fast. There has to be something. Maybe rectal works slowly over a long period of time or something. This is pharmacokinetics wahala. After we figure it out. Yes, Sarah, you called me. You wanted to tell me something. 5-year-old lady presents with a 6-hour history of facial droop and weakness in the left side of her body. What single agent would she be prescribed for her whole life? 5-year-old lady presents with 6-hour history of facial droop and weakness on the left side. And she had a stroke. All right. Let's assume that it's an ischemic stroke. What single agent will she be prescribed for her whole life? Will you keep giving her Ateples all her life? Clopidogrel, aspirin, labetalol. Dr. Agatha, can you see the questions? Let me use it as the rate limit instead. That's the thing. It could shock you now. Let me So I'm back. I would think that you guys should have been solving the questions, like even one person would have taken over the mic. Can you guys see the questions now? All right. So proceed. Final answer. Which answer did you choose? No, yeah, you didn't choose. Okay, you chose Vasoprene. Chara, your fears have been confirmed. But somewhere we read something about this clopidogrel. The key is a clopidogrel. Ongoing symptoms are considered as stroke unless completely resolved within 24 hours. Hence, clopidogrel is the answer here. As they want lifelong. You don't understand them. The use of clopidogrel and Vasoprene. It's our history of facial droop and weakness. See, let's consult this there. We saw this in under cardiology, in neurology. That's that use of clopidogrel. Okay. Can you guys still hear me? Okay, it's loading now. Yes. So what I want is somewhere that can compare the uses of each one and like the situations where you have to use each one of them. Recurrent stroke is common immediately following a transient ischemic attack. Or I think I remember that was the time that we found out that when someone has a recurrent stroke, you tend to add clopidogrel. A 65-year-old lady presents with a 6-hour history of facial droop, blah blah blah. What single agent will she be prescribed for her whole life? Yeah, I'll find it. I'll take it up. I'll ask some bigger chips, the neurologists. Yeah, of course. Okay, you mean like clopidogrel is preferred? No, I think it's the situation that determines. This one is about a 45-year-old lady who presents with a history of double vision and facial numbness. Which anatomical site is most likely to be affected? Diplopia, facial numbness, all right? Cerebral cortex, trigeminal nerve, oculomotor nerve, brainstem, basal ganglia. Talking about the sensations. That double vision now, what do you think is causing the double vision? Is that ophthalmoplegia? Like extraocular muscles affectation or something? Which means it could be nerve. Unless trigeminal has something to do with the eyes that I'm not sure of. I know it has an ophthalmic branch, but it's sensory nerve. The sensory nerve, it will not cause double vision. Double vision implies that the extraocular muscles are affected. So it's the brainstem. I think we're going to 40% now. Yes, finally. The final question for today. A 50-year-old man with a known history of stroke. He can't remember anything about his life. What's the single most likely defect? About his life, Jesus Christ. With a known history of stroke, he can't remember anything about his life. What's the single most likely defect? Homonymous hemianopia, homonymous upper quadrantonopia, bilateral hemianopia. It's not matching, Abi. Like the question and the answer doesn't match. 50-year-old man with a known history of stroke. No match. All these ones have to do with optic pathway now, visual pathway. You can't see the questions again. All right. Okay, now this one will be our last then. A young lady presents with gradually worsening headaches, visual disturbance, and lack of energy. MRI shows 15 millimeter tumor in the pituitary fossa. What was the treatment of choice? Presents with gradually worsening headaches, visual disturbance, and lack of energy. MRI shows 15 millimeter tumor in the pituitary fossa. What was the treatment of choice? Radiotherapy, octreotide. This is a pituitary adenoma. Surgery, chemotherapy. Oh, you are not seeing it for real? All right. They can just go in and remove the pituitary adenoma, big surgery. So when there's a lesion in that place, to gradually obstruct the optic chiasma, compress the optic chiasma, leading to some symptoms, blurring of vision, double vision. So what will you call that vision? What will you call it? Like that lesion on the visual pathway when it is, yes, bitemporal hemianopia. That's the lesion. Yeah. So it's surgery. Yeah, it's surgery. Tumor that causes pressure symptoms like headache, visual disturbance, and large size of the tumor are indications for surgery removal, surgical removal, right? So any questions on the CNS or anything that is confusing you before we go? You say MRI shows 15 millimeter tumor. Abi, you know big. You know that place is very small. This 15 millimeter now is 1.5 cm. That's like one of your fingers, one of your small fingers, right? So that's big for that place in the brain. Any other question? In the absence of questions, yeah, patient already has pressure symptoms, which shows you that it's big. Yeah. All right, Sarah. Any questions from you, Agatha? Please, let's hear your voice once today. What's that topic that we even had? Did you meet dementia? I'm not sure you met dementia. Did you meet when Korsakov? Oh, voila. All right. So, okay, no question. All right. So, let's end it here. You guys tomorrow. Continue. If you continue like this, let me project when we'll finish CNS. 50 tomorrow, 50 on Sunday. It's like you guys don't like coming to discussion on Sunday. What happened? You're keeping the Sunday holy. If you don't want it to, let me scrap it so that I will know I'm resting on Sunday. What's the consensus? Going on a biblically. We are not working now. Are we working? We are not working. We are resting. We are resting and learning. Did God say you should not learn on Sundays? On Sundays, you just switch off your brain. I don't learn anything. Okay. All right, guys. No wahala. Good night. Problem, no rest. Allowed. Take care.